Now we are in the session of heart failure, and I'm glad to co-chair with my dear friend Professor Osama Sanad. The first speaker, Professor Dr. Sayed Farag, the advances in the medical therapy of heart failure with reserved ejection fraction.
Thank you, Mr. Chairman, for the kind introduction. Let us continue. I think it is very fantastic CME Day. I think we dive on most of the topics in cardiology, and we are now in one of the most important topics, and I think it is now the current topic of every hour is the advances in the medical therapy of HFrEF, because actually we have a new weapons that we can change with that the face, the aggressive face and the bad face of the heart failure, which I think in the previous year was not less than those with malignancy. This is the magnitude of the problem. It's really grave. Heart failure is a major public health problem with current worldwide prevalence of heart failure estimated to be 64 million cases. Imagine 64 million cases, and heart failure is an emerging worldwide threat whose prevalence and health loss burden are constantly increasing. The heart failure is a major problem, and you see here about 65 million all over the world. Another major problem here that around 50% will die within 5 years of diagnosis. How grave it is. Mortality rate in heart failure are high even for patients compliant with the best available medical therapy. Even with the best available medical therapy, there's still 50% die within the 5 years of diagnosis. When heart failure symptoms are stabilized by current treatment, it may seem that the patient are doing well, but unfortunately, the neurohormonal imbalance which are acting there underlying the heart failure is still silently occurring, resulting in the disease progression, which is very grave. It is not only the health care burden, but also the economic burden. Heart failure imposes a significant economic burden on the healthcare system. 70% of the cost of heart failure is due to hospitalization. Yes, when I was a resident and assistant lecturer, most of the ICUs filled with cases with heart failure, staying in the hospital for more than 2 weeks, and sometimes 2 or 3 days, 1 week, and they back again to the ICU. It is a cost burden over every healthcare authority. Of course, it means a lot of billions of dollars, about 65 billion direct costs for the medications, for the hospital stay, and of course around 43 billion indirect costs because of absenteeism from work and from stop of the productive activity. If we have an international data, we have also Egyptian data, which is very, very valuable, and it is very prestigious that the chair of Egyptian data by Professor Hassanin and his group for those patients' clinical characteristics and management of hospitalized and ambulatory patients with heart failure, the results from the ECC heart failure long-term registry. I'd like to inform you a very important data from this publication, that about acute decompensated heart failure was the most common presentation. 50%, more than 50% of patients presented with acute decompensation. From those 2,000 patients hospitalized heart failure, about 70%, and congestive heart failure about 30%. You can appreciate here the high percentage of those patients with hospitalization, with decompensation, and those patients with chronic heart failure from the Egyptian data, and even those patients under all the medical treatment available at that time, from RAS blockade, beta blockers, and MRAs, we still have those figures, those grave figures for hospitalizations and congestive heart failure. We have a long journey starting from ACE 87 and beta blocker 96, first MRA 99, first ARB 2001. Yes, we have a cluster of good medications at the start of this century, but unfortunately, despite this very good bunch of medication, we still have a high mortality and morbidity and hospitalization. Those were the guidelines in 2012, and it is based upon the neurohormonal axis blockade by the RAS blockade, the MRA and the beta blocker as a cornerstone for treatment, but unfortunately there is no more than this treatment in 2012, which is evidence-based. Till 2014, when the breakthrough revolution came up to the stage with the sacubitril valsartan and the very important trial, which is the paradigm, which showed us the revolution in the treatment of heart failure by the Entresto. We have at that time the block of the sympathetic nervous system and the renin-aldosterone system blockade by the valsartan, but we still have the issue of elaborating and make the natriuretic peptide system free for their beneficial effect, and this was done by the sacubitril molecule to get the beneficial effect of the natriuretic peptide system. And so now we have blocked the bad pathway and give the good pathway to be free, and this is what the Entresto did and changed the face of heart failure treatment. And we can see in the paradigm a marvelous results for 20% risk reduction for cardiovascular death, first heart failure hospitalization, sudden cardiac death 20%, and 16% reduction of this from any cause, and also 23 fewer admission for heart failure and 80% fewer stay in intensive care. Very marvelous reduction and percentage of reduction between enalapril and sacubitril valsartan, which is actually changed the face of treatment heart failure. And that's why in the guidelines 2016, it came to the stage as a class 1 indication to replace ACE inhibitor with ARNI because of its very beneficial effect as regard the mortality and hospitalization. And as you see here that from the guidelines that sacubitril valsartan is recommended as a class 1 level of evidence B as a replacement of an ACE inhibitor. This was in 2016. And the evidence is going on after 2016 for the Triton study and transition study for those patients with and those patients following stabilization after acute decompensation heart failure by the Pioneer heart failure, and also for those patient naive and the patient hospitalized for heart failure naive for ACE, and they prove also beneficial effects for both patterns of patients, either those stabilized after decompensation or patient naive. Still they have beneficial effect from giving them Entresto. Actually, another revolution came up to the stage, which is the SGLT2 inhibitors in those patients with diabetes and without diabetes for treatment of heart failure, and they're proving a great efficacy. The SGLT2 inhibition promotes natriuresis, osmotic diuresis. Those are the beneficial effects, leading to plasma volume contraction, which is very beneficial in those with hypertension, reducing the preload and decreasing the blood pressure, the arterial stiffness, and afterload as well. And all those are very beneficial in those patients with hypertension, with heart failure. And of course, here came up also the very important landmark trial, which also changed the face of the management of the heart failure, which is the DAPA heart failure in 2019. We can appreciate here how the dapagliflozin is significantly decreasing the cardiovascular death, heart failure hospitalization, and urgent heart failure visit. Also, the worsening of heart failure event significantly with a lot of zeros between the dapagliflozin and placebo. Cardiovascular death is also significantly improved. Cardiovascular death or heart failure hospitalization also significantly with a lot of zeros again, significantly improved. The total heart failure hospitalization, cardiovascular death also significantly improved. And we can here appreciate that those patients who are given either in the Emperor reduced for empagliflozin or dapagliflozin DAPA heart failure, they were under RAS blockade and ARNI, and that's why this is giving the beneficial effect, how the SGLT2 are beneficial in those patients even if they are given the maximum treatment, including ARNI. And here is, as you see, the results of the Emperor Reduce, which is also significant reduction of hospitalization and cardiovascular deaths. So that's why the American College of Cardiology gave us a very important pathway evidence for treatment of heart failure, that ARNI, ACE and R, but they give a preference to ARNI for stage C heart failure. And if the patient is with eGFR more than 30, we have to add aldosterone. And if also the eGFR is above 45, we have to add SGLT2 inhibitor. We also can give diuretic if the patient is overloaded. And for some patients who are plaque, we can add hydralazine isosorbide. And for those patients who are uncontrolled for heart rate reaching the target 70 despite maximum tolerated dose beta blocker, we can add ivabradine. So as you see here, from 2012 to 2021, we have a total change for the treatment of heart failure, and definitely it is for the better. And in 2021, actually came now the clear strategy for treating the heart failure with the 4 pillars: ACE or ARNI, beta blockers, MRA, dapagliflozin, empagliflozin, and loop diuretics for those who have fluid retention. Those are all with class 1 recommendations. So you can see now, after a very few years, the sacubitril valsartan and the SGLT2 inhibitors came up to the stage with class 1 indication in the treatment of chronic heart failure. The triad was beta blocker, ACE or ARNI, MRA, and also, if there is no contraindication, the dapagliflozin or empagliflozin should be added, was also class 1 recommendation. I didn't find a much more better than this slide for concluding my presentation, that all those drugs are class 1 level of evidence A as a recommendation: ACE, beta blocker, MRA, dapagliflozin, and also sacubitril valsartan as a replacement of its inhibitors with HFrEF. All are class 1 recommendation. About 7 or 8 years ago, we have only 2 or 3 drugs which we can use in the treatment of hypertension. Now we have 6 drugs which we can use with a class 1 recommendation in the treatment of heart failure. Not only this, but also with a very clear reduction of cardiovascular death and hospitalization. I need only 1 minute or maybe 30 seconds. A very important message also here is that for those patients, initiation of sacubitril valsartan in ACE inhibitor naive now is given up a recommendation in the latest guideline, which is, yes, it is 2B, but it is there even in patient with AC inhibitor naive patient. This is an European. But I'd like to remind you that in the American College of the Cardiology, American Heart Association, it is in class C, it is like a recommendation, level of recommendation A, to giving the preference for ARNI as a treatment of heart failure with reduced ejection fraction. At the end of my presentation, I'd like to say that heart failure now is not like before, because we have innovations, because we have drugs which are reducing mortality and reducing hospitalization, and of course it will be reflected in healthcare authorities as regard their strategies of management and the economic burden. Thank you for your attention.
Thank you very much.